Last March, when Kim told me about her work developing these education models for end-of-life care in acute hospitals, I was really, really pleased. And like Villa said, I think it's important because the reality is acute hospitals are where a lot of people die. The skills and conditions for good end-of-life care, I think, should be available where people are when they die. Well, you might be thinking, as acute physicians, we do deal with dying patients all the time. We kind of got the hang of it. But the truth is, however, that the acute care setting has its challenges. One, it's a busy place, and dying isn't a busy thing. Good dying requires time when you're under pressure. Including family and friends requires space when space in an acute ward is often at an absolute premium. And I think end-of-life care requires a very different focus, from treatment with the aim of cure to one that's about managing symptoms to maximise the dying person's comfort. So yes, you're dealing with patients dying all the time, but the question to answer is, why try and do it better? And how can you in the acute setting? So I should tell you a little about my own experience in end-of-life care, because I guess it explains why I value it. And the truth is, I am no expert, and I don't see myself as one. I have absolutely no medical or academic expertise. The best I can offer is to articulate what the experience of good end-of-life care means for the non-medical person. And so for me, that really began 10 years ago in 2006. My son, who had been diagnosed with acute myeloid leukemia 6 months before, died, as it would happen, on his 20th birthday. Now, however untimely his death was, I do know he had a good dying. What do I mean by good dying? Well, several things really. Firstly, all the medical events that occurred during those last few days. He had, I think it's an infarct of the spleen, pain, delirium. They were all dealt with promptly, so his distress, and ours, was minimised. He understood he was dying, and so he could prepare himself. And his choice was to marry his childhood sweetheart 2 weeks before he died and write letters of farewell to his sister. He got to say goodbye to us, and we got to say goodbye to him. And lastly, he died in a room full of people who loved him. I also know that sharing his dying meant that we, the living, could share our grief and ultimately get on with living. Dying happens to the individual, but its impact is social. This is why it matters. And look, in the acute setting, it is a challenge to make the time to have the conversations the patient and their family may want and need, especially as it's unlikely the patient in the acute setting has much time. Maybe making time is a question of understanding what a difference it makes to the patient and their family. And dare I suggest, where there's a will, there can be a way. Then there's the problem of space to include family and friends. In the acute setting, the simple lack of space can make all these extra people seem like an intrusion. But there are ways of managing them. Finding a room or a space away from the bedside is really useful. Respectfully but firmly limiting the number of people who can be at the bedside at any one time is another. And I have to acknowledge family and friends do bring such a mixed bag of emotions to the clinical setting, with their often widely varying degrees of recognition or acceptance of the imminent death of their family member. And occasionally a death brings to the surface all those old family squabbles just to add to the complications. I'm not suggesting these are your problems to solve, but if you understand what's going on, where people are coming from, it does make them easier to deal with. You in this situation are the professionals, and the truth is the patient, their family and friends are actually looking to you for two main things, to my mind. The first is management of any symptoms causing distress or discomfort to the dying. And for example, delirium can be a common occurrence during the course of dying. And to my mind, it's the most distressing thing to witness as a family member. Yet, this is exactly the sort of event where you, as the professional, can give context to what's happening, as well as the prompt treatment needed to alleviate the patient's distress. Patient, family and friends are looking to you for reassurance and guidance about what to expect as the process of dying is experienced or witnessed. And part of that is helping people understand that dying does not follow a precise timeline. Your patience and your respect for the dying person does an enormous amount to contain a lot of emotion and anxieties when both the patient and the family can feel a bit out of control. Look, I could rabbit on, but I won't. For me, the essence of good end-of-life care is a combination of kind personal care, timely access to the good management of symptoms, and the inclusion of those who are dear to the dying. I'm not saying it's a simple thing, but I do believe it's possible to achieve it in the acute setting. So I commend Kim's work to you, and I encourage you to make good use of them because, in my view, in the end, I think we all will benefit. So thank you.